Hi everybody, we're going to pick up on page 44 in your course pack and talk about cardiac output and regulation of stroke volume and heart rate. I just want to remind you that this is a great time to go back and review blood flow. If you haven't yet learned it, it is found on page 38 in your course pack. And it's also a good time to remind you that the starting point for blood flow can be anywhere. Just because the page 38 information starts with SVC, IVC, and coronary sinus, do make it a habit to pick any place as your starting point and take the blood flow back to that same place as your ending point. So cardiac output is the amount of blood pumped by the heart in 1 minute's time. It is dependent upon two factors or variables, stroke volume and heart rate. We know that stroke volume is represented by SV, heart rate, of course, is HR. So to repeat, cardiac output is the amount of blood circulated by the heart in 1 minute's time. So we've already discussed stroke volume, and we know it's around 70 milliliters of blood. That's the amount of blood pumped from each ventricle of the heart during ventricular systole. We also know the average resting heartbeat is 75 beats per minute. So if we multiply those two together, we get 5,250 milliliters of blood circulated per minute. Do a simple conversion from milliliters to liters, and you'll get 5.25 liters per minute. So on average, I'm going to use X bar for average, we're looking at around 5 liters of blood circulated per minute for the average person. Now, if you think back to when we discussed blood, the average female had, around 4 to 5 liters of blood. The average male had 5 to 6. So a common value for both males and females would be around 5 liters. So this goes back to what we've already learned about how much blood is in the human body. I also want to remind you that these values here, stroke volume and heart rate, are directly proportional to one another. If stroke volume increases, so will heart rate and cardiac output. If any one of these volumes decreases, they'll all decrease. So we're looking at these being directly proportional to each other. That means they're related and will all either go up together or down together. We can also figure out stroke volume by calculating it from end diastolic volume and end systolic volume. We know from an earlier discussion that end diastolic volume is around 120 milliliters. What is end systolic volume? That should be around 50 milliliters. So that should give us a stroke volume of around 70 milliliters on average. So if you're not readily given the stroke volume, do know that you can calculate it if you have the end diastolic volume and the end systolic volume. Let's talk about what influences or affects stroke volume. These three terms: preload, contractility, and afterload. Preload is the blood coming into the heart. So let's focus on the picture on the left. When blood comes into the right atrium, it arrives from SVC, IVC, and coronary sinus. That blood then travels through an open tricuspid valve, and it arrives here in the right ventricle. The amount of blood at the end of diastole is what we call that end diastolic volume, about 120 milliliters. Likewise, the left atrium receives blood from 4 pulmonary veins. That blood travels down through an open AV valve on the left side called the mitral or bicuspid valve. And of course, it comes down here to the left ventricle, and that again would be an end diastolic volume of 120 milliliters. Okay, so we're looking at each ventricle of the heart receiving about 120 milliliters of blood at the end of diastole. That is basically what preload is. It's how much blood you can load into the heart, and so that means that preload and EDV are approximately the same. Afterload is the pressure that must be overcome for blood to be ejected from the heart. We'll come back to that in just a moment. So preload is approximately end diastolic volume. It is the stretch experienced by the ventricles before they contract. Think about it this way. Imagine the heart as a muscular, stretchy organ. The more blood you put in there, the greater the stretch those walls must experience. And so the greater the stretch they experience, the stronger the contraction when they do pump that blood back out. So we expect to see preload increased by venous return and venous pressure. Those two things can occur with exercise. So if you're putting more blood back into the heart and those walls stretch, That's how we can cause the heart to hypertrophy or enlarge in size during exercise. Preload is decreased by nitroglycerin. Nitroglycerin is a drug that helps to reduce the amount of oxygen demanded by the heart muscle tissue. Therefore, if you have nitroglycerin in your system, then preload will decrease. That means the stretch in those walls will decrease. That's why nitroglycerin tablets are given to people who may experience angina, because it reduces the load of oxygen required for the heart to operate. Okay, so a couple of things to remember here. I'm going to circle EDV and stretch. These are two good things to keep in mind when you think about the word preload. Contractility is the strength of the muscle contraction. And before you read the rest of this slide, let's think for a minute about rubber bands. If you have rubber bands, then fresh, brand new rubber bands have great stretch. That's preload, right? And they have great strength. That's contractility. If you have old, really old, dry, and worn out rubber bands, they may no longer have any stretch. That's preload. And they'll also not have any strength. That's contractility. So that's why we want heart muscle to have good stretch and good strength, because that increases the force of contraction and makes the heart have to work less hard. So contractility is the strength of the muscle contraction. That's the ability of the muscle to shorten and produce an ejection of that blood out through the two arteries. Contractility is increased by anything that increases the strength of the contraction. That could be calcium ions. That could be sympathetic stimulation, which includes epinephrine and norepinephrine. That can include glucagon. Glucagon raises blood sugar. What does thyroxine do? Thyroxine increases metabolism. There's a drug here, digitalis. Digitalis also increases the strength of contraction, especially in those who may have a failing heart. Contractility is decreased by excess potassium. This term here, hyperkalemia, means there's too much potassium in the bloodstream. That will increase the resting potential. I'm going to put RP there for resting potential, and makes it harder for that heart to reach action potential or threshold. Calcium channel blockers are drugs that decrease the strength of contraction. That may be useful for someone who has a heart that is over-responsive or overworking. So just a good reminder here from Bio 210, the role of calcium in muscle contractions. Calcium's presence will allow for these ropes of tropomyosin, these right here, to move away and reveal binding sites on those actin filaments. The more calcium that is available, the more of those binding sites can be revealed, and of course those myosin heads can reach up and bind to those actin binding sites if they're available. Back to afterload. This is the pressure in the arteries that we must overcome in order for blood to be ejected. Why do we focus specifically on that left ventricle? Well, that's the one that experiences the highest pressure. The left ventricle experiences a pressure of around 120 millimeters, and the right ventricle only experiences a pressure of around 24 millimeters mercury. So it is that left ventricle that must overcome pressure in the aorta here in order for the blood to be ejected. So afterload has little effect on preload because there is a lot going on in systemic flow before that blood ever gets back to the heart. However, preload does have a direct influence on afterload. Remember, what comes in is preload, what goes out is afterload. So another good term to remember here is pressure when you're thinking about afterload. All right, so if you will turn the page with me and head over to 45, let's talk about what increases heart rate and cardiac output. First of all, sympathetic nervous system activity can directly influence heart rate. You may recall right here is the heart, and we have hormones like epinephrine and norepinephrine that will increase the rate of the SA node and the AV node. You may recall these receptors here, alpha and beta receptors, that work for the sympathetic nervous system. They're adrenergic receptors, meaning they bind adrenaline. Keep in mind, the other name for adrenaline is what? Epinephrine. So norepinephrine and epinephrine both can excite these alpha and beta receptors, in turn causing the heart to contract more quickly. So that will increase heart rate. All right, so we've taken care of epinephrine and norepinephrine. What impact does thyroxine have on heart rate? Well, it increases the metabolism, so heart rate will then increase. Glucagon increases blood sugar levels. That too will cause the heart rate to increase. Let's talk about ions. High calcium levels can cause abnormal heart rhythms. We just talked about how extra calcium can reveal those binding sites on actin filaments by moving the rope of tropomyosin away. That allows for those myosin heads to bind and increase the contractility or the strength of that contraction. Likewise, low potassium levels or hypokalemia can make the heart more excitable, and action potentials are more likely to occur. So notice the really similar spelling here. Hypercalcemia and hypokalemia both can cause an increase in heart rate. Okay, so here once again you see the effect of calcium on those ropes of tropomyosin, allowing us to reveal binding sites on those actin filaments. And I just wanted to show you this picture so we could talk about potassium for just a moment. The less potassium you have inside your cell, the harder it is for you to reach, or the easier rather it is for you to reach threshold. So if you kind of create an imbalance here, instead of having a negative 70 millivolt resting state, you may be closer to threshold, which is approximately negative 55. So if you're negative 60 millivolts at your resting stage, then it doesn't take a whole lot of disturbance here to increase you to negative 55, and boom, you've hit threshold at that point. So hypokalemia can increase the excitement of that muscle cell in the heart. High temperature, heat, fever can increase heart rate, as can caffeine, probably one of our most favorite drugs, found in caffeinated drinks like tea and soft drinks, and in coffee and chocolate, of course. By contrast, parasympathetic nervous system activity can decrease heart rate. The parasympathetic nerve that travels to the heart is the vagus nerve. You may recall that's cranial nerve 10. And the vagus nerve slows the rate of that SA node. Okay, so you may recall acetylcholine is the hormone, or the neurotransmitter rather, released by that vagus nerve. Now, atropine is a drug that works against the vagus nerve. If the vagus nerve is slowing heart rate, then atropine will increase heart rate. Okay? Now, if someone has an overactive vagus nerve and it's releasing too much acetylcholine onto the heart, then they may experience what's called vasovagal syncope or syncope. This is just a fancy word that means fainting. Okay, so if that vagus nerve is overactive and producing too much acetylcholine onto the heart's SA node, then the heart rate may slow to a point that produces fainting. Now, this last term, vagal maneuver or Valsalva maneuver, is a process by which you hold your breath, you stimulate the vagus nerve, and you lower the heart rate. That's actually one of the few ways that you can increase the vagus nerve's ability to release acetylcholine onto the heart. So you can hold your breath, you can have a deep hearty cough, you can hold your breath as if you're having a bowel movement, picking up a heavy box. Those kinds of activities will help you to stimulate the vagus nerve and lower the heart rate. Now, if you're really nervous about something and you feel your heart pounding out of your chest, try deep, slow breathing, coughing, or holding your breath. All of those will stimulate the vagus nerve and lower the heart rate. Just as a side story here, people who take heart rate medications like alpha blockers and beta blockers. So let's think about that for just a minute. These blocker medications have as their job to lower the heart rate. If someone takes one of these medications and then is trying to pass a bowel movement by holding their breath, that can in turn further lower the heart rate. So people in nursing homes are oftentimes given stool softeners to help them have an easier bowel movement, because if they sit on the toilet and hold their breath and they take an alpha blocker or a beta blocker, they may pass out, fall off the toilet, and hit their head. So we know that there's a certain number of emergency calls for those types of accidents where people fall off a toilet. By the way, the Valsalva maneuver is how we think that Elvis died. You know, Elvis Presley back in the 70s died from sitting on a toilet having a bowel movement, and he might have been on some medications that exacerbated his heart rate lowering. All right, so just a reminder here that vagus nerve, cranial nerve number 10, is the wanderer. It does travel away from the cranium or brain, and it does innervate the heart, and its job is to slow heart rate by releasing acetylcholine onto heart muscle tissue. That slows the SA node. Okay, just another reminder of the vagus nerve. Now, notice that we're flipping the scenario this time. To decrease heart rate, we may see low calcium, which keeps those binding sites covered, or we may see high potassium levels, which can cause fatal arrhythmias. So insulin is something that can play into this issue here of having hyperkalemia. Regulating blood sugar involves exchanging hydrogens and potassiums, and of course, if you put potassium in a cell, then it can increase that resting potential, making it harder for those heart cells to depolarize. Okay, so drugs like these three here, alpha blockers, beta blockers, and calcium channel blockers, can all decrease that heart rate. All right, so that should take you through page 45. Let me take you over to page 46 for just a moment. Congestive heart failure is also known as chronic heart failure. CHF covers either case. And we see this as a progressive chronic disorder that is not something that we can correct. It is something that we can simply provide treatment for and to give comfort to the person with this condition. Coronary atherosclerosis is clogging of the vessels with fatty deposits. Over time, they will become hardened, and we end up with an end-stage disease called arteriosclerosis. High blood pressure that is chronic and untreated can cause the heart to enlarge, become a big, flabby organ that is unable to contract as it should. Multiple heart attacks can damage heart muscle tissue, rendering the heart as a useless pump. And then dilated cardiomyopathy literally means a big, flabby heart. We know that big, flabby hearts are ones that are unable to contract and efficiently pump blood. Great YouTube video here. You may want to copy and paste that link so that you can watch that one. There's two types of heart failure. There is left side and right side heart failure. Be very careful when you think about this. If the left side of your heart fails, let's put this down here for just a moment. If this is your heart and this is your left ventricle, backflow the blood. It goes back up into the left atrium because the left ventricle is unable to effectively pump out that blood. Where does the left atrium receive blood from? Well, from 4 pulmonary veins. Those pulmonary veins, of course, come from the lungs. So if we backflow the blood up to the lungs, then we're going to experience a congestion or suffocation effect where we've got fluid accumulating now in the lungs. So it's very important that you think backwards here, because that's how we expect to see left side heart failure. We see pulmonary congestion and edema because blood and fluids back up to the lungs. Likewise, right side heart failure. Let's put a heart right here for just a moment. If the right ventricle is unable to contract and effectively pump blood out, blood flows backward to the right atrium. The right atrium is fed by the SVC, okay? Down here by the IVC. And the coronary sinus, well, gravity, of course, pulls blood down toward the IVC. So then we see swelling in the hands and feet. We see swelling around the belly called ascites, this term right here. And we also see swollen fingers, swollen toes, socks cutting into the ankles. So this particular condition won't necessarily cause fluid around the lungs, but it will cause fluid to build up in all of the extremities. Over time, one side of the heart compensates for the other, and so right side heart failure may cause complete heart failure, or left side heart failure may cause complete heart failure. Okay, so I encourage you to take a look at this website right here, Watch, Learn, Live at heart.org. That gives you a great animation that you can walk through and watch how heart failure can cause one side of the heart to weaken and enlarge, and how the other side will eventually become the same. It too will weaken and become enlarged due to its compensation for the other side of the heart. So this particular condition is not something that we can cure. It's only something that we can treat. Okay, and the treatments are listed there on the bottom of page 46. Just to wrap up this chapter on page 47, myocardial infarction is MI, or a heart attack. This is when the cardiac muscle is deprived of oxygen. It can cause those heart muscle cells to die. Now, we know that heart muscle does not repair itself, so once we see that we've got damage to the heart, scar tissue may replace those damaged heart muscle cells. There is good news on the horizon. There may be ways for us to regrow heart muscle and replace that damaged tissue, that scar tissue, with functional new heart muscle cells. So maybe we'll see that in years to come. Angina pectoris is a condition where the heart muscle is temporarily derived of oxygen, and this may be due to exercise, climbing stairs, coming up a hill, and it's a fleeting heart pain, but it can be a warning sign for something more sinister looming on the horizon and should be checked. On your worksheet, you'll notice that there are two ways to diagnose a heart attack: troponin and creatine kinase. Creatine kinase just indicates muscle damage. It doesn't specifically indicate what type of muscle, so troponin is a more specific indicator for heart tissue damage. Heart tissue damage can come from blockages due to a thrombus that travels from elsewhere in the body. It can block a heart vessel, a coronary artery. It can also come from fatty blockings in those coronary arteries that may cause a rupture of a heart vessel, and that too can lead to a heart attack. Heart attack symptoms are different for men and women. You'll notice these listed here are typical for men: chest pain and discomfort, left arm pain, left jaw pain, nausea, vomiting. Those kinds of things may come with heart attack symptoms, shortness of breath. Female heart attack symptoms are sometimes more mild. A lot of times women indicate that they have unusual fatigue. They feel like an elephant is sitting on their chest. Oftentimes these symptoms may mirror image just exhaustion or perhaps an illness that one is coming down with. However, that may be the only warning sign a female has. So I'll share a quick story with you. I had a female student in her 50s in class a few years ago. We talked about these symptoms and especially how they're different for women than they are for men. She said that she oftentimes had shortness of breath and some discomfort in her chest when she came and went from the 5000 building. She went to her doctor and was checked out. She disappeared from my class because she ended up having open heart surgery and a 3-way bypass. She came back to school the next semester and was really emotional. We talked about this during class, and she said that this conversation is what pushed her to get checked. So it saved her life, and I encourage you to pay attention to those around you and the symptoms that they have, because these mild symptoms may be all the symptoms a female has in terms of heart attack symptoms. So notice the website down there, womenshealth.gov/heart attack is a great place to look to read more about heart attack symptoms for a female. I'll let you read the rest there about treatment and a little more about angina on your worksheet, and I'll just draw your attention to the bottom of the page. There are fetal bypasses in the heart that allow for a fetus to not have to get oxygenated blood from the lungs. Of course, a fetus gets oxygenated blood from mom. So there is a hole in the heart called the foramen ovale that closes after birth, and we see a remnant of that piece called the fossa ovalis. If it remains open, it's called an interatrial septal defect or patent foramen ovale, one that tends to remain open. Otherwise, it's just simply known as a hole in the heart. There's another bypass here called ductus arteriosus that becomes ligamentum arteriosum after birth. And again, if it remains open, it may cause a problem called patent ductus arteriosus. So let's talk for a moment about what these openings, foramen ovale and ductus arteriosus, originally connect in a fetus. So here you can see foramen ovale right here. It's a hole between the right and the left atrium. That hole allowed for blood to bypass and go directly from right to left atrium. It prevented the blood from having to fully go through, pulmonary circuit down through the right ventricle and then back through this systemic circuit on the left side. Now, of course, blood did flow through those areas, but we're not relying on the lungs to provide oxygenation of blood. That is, of course, provided by the placenta that you can see over here. Okay, so that hole should close and become a fossa ovalis after birth. Okay, so it's meant to be there in a fetus before birth. It's not meant to be there after birth. Here you can see a connection between the pulmonary trunk and the aorta. It should be closed after birth. However, if it stays open, it allows for deoxygenated blood here in the pulmonary trunk to mix with oxygenated blood here in the aorta. So this patent ductus arteriosus should have closed, but in this case here you see it's not actually. It allows for a mixing of deoxygenated and oxygenated blood. So sometimes people have headaches, migraines, lightheadedness, shortness of breath, that kind of thing, if they have these kinds of patent openings that persist after birth. Okay, and just another view there of that patent ductus arteriosus. It is a remnant of an open passageway that should have closed upon birth. Like I mentioned, great time to review that blood flow. Please flip back to page 38 and take a look at that blood flow, being sure that you feel comfortable with any point as your starting and ending point.